Okay, how does it look on your end? Okay, good. Wonderful. Thank you both so much for the very generous invitation to be here today and speak at this webinar. I'm very privileged and honored to be here. So as mentioned in the introduction, I'm a bioethicist. I'm also an interdisciplinary scholar. So the talk that you're going to get here today is going to be very applied. So just to mention that, and I'm going to talk about some work I've been doing, things I've been thinking about over the last number of years about notions of diseases, brain diseases, and how that interfaces with various contested conditions, such as chronic pain, mental health, and substance and addiction, or substance use and addiction. I'm joining you today from Toronto, or Takaranto, which is Treaty 13 that was signed with the Mississaugas of the Credit. And what you see up here is the land acknowledgement from the Center for Addiction and Mental Health, which is where my primary appointment is in Takaranto. Just first, some acknowledgements and mentions of funding that's informing the work today. First, I'm going to draw upon some of the work that I conducted with my colleague, Dr. Suze Burkhout, in our chapter in the Routledge Handbook of Feminist Bioethics on feminist bioethics perspectives on neurobiological approaches to addiction and chronic pain that was mentioned in the introduction. I'm also going to draw upon some empirical data, which would be fun for a philosophy seminar, on some research projects that I'm undertaking with sort of very generous funding from the Canadian Institutes of Health Research. I'd also like to acknowledge my colleagues at the Center for Addiction and Mental Health and Education, where I have my scientist appointment, as well as the wonderful group that makes up the Everyday Ethics Lab, which I have the privilege of learning from every day. So many of the ideas that I'm going to present here today and discuss with you all are very much shaped by my spirited and very thoughtful interactions with wonderful students and colleagues from these places. So in this talk, I'm going to explore how what I and others have referred to as the contemporary neuroculture is shaping historically contested ideas of addiction and also mental illness within a brain disease model, and how this has begun to extend to understandings of chronic pain. So I'm going to describe some of the parallels between brain disease models of addiction and mental illness and the emerging model of chronic pain as a disease, or as a brain disease in particular. I'm going to discuss some of the ethical strengths as well as the ethical vulnerabilities of brain disease model of chronic pain. And I'm going to argue that the ethics lessons that we've received from the brain disease models of addiction and mental illness actually offer a cautionary tale for chronic pain stigma. I'm going to sort of mention what I'm not going to do. I'm not going to argue for a particular account of a disease or argue for the idea that chronic pain is a disease. My concern here is both with the ethical benefits and the drawbacks of disease-based explanations of chronic pain and the implications this has for stigma. So I want to suggest that we are living in a neuroculture. So we as human beings are increasingly understanding ourselves in terms of our brains. So in the early 20th century, more and more people in Western countries started to focus on the brain rather than, perhaps the heart as the location of the self, and began to conceptualize themselves in neurochemical terms. So maybe some contemporary examples, you might say, if anyone's out there is a runner, I am not a runner, but if anyone else out there is a runner, you might say, oh, I got such an adrenaline rush from that run. Or, on social media, I'll like all the likes because they gave me all these dopamine hits. So that's sort of like this folk psychology, this folk neuroscience that we are starting to sort of incorporate into our everyday language. Victoria Pitts Taylor has argued how human experience is increasingly understood via brain regions, neurons, and neurotransmitters. Joel Abirached and Nicholas Rose have talked about the contemporary neuromolecular gaze. and how that's reflected within a modern neuroculture where images of the brain from the brain sciences circulate widely. Neuroscientific knowledge has become authoritative and prolific, and neuroscientific explanations can have what some people have referred to as a seductive allure, shaping various publics' ability to critically interrogate explanations of psychological phenomenon. And in many ways, I think, the brain has become sort of the equivalent of the modern soul and the very seat of our identity. We can see here just some examples of the neuroculture in everyday life. Many of these are probably familiar to many of you. So for those of you familiar with listening to Prozac, very influential book that came out in the 90s, Peter Kramer explored how Prozac changed the brain of many of his patients, and ultimately he said their personalities. He raised various questions about authenticity, who's the real person on or not on Prozac. Folks may, if you look at sort of the top left-hand image there of the egg and the pan, and the people may be familiar with this very anti-drug messaging coming from the U.S. many years ago. This is your brain, this is drugs, and then the egg that's been splattered in the pan, this is your brain on drugs, so very fear-mongering. Sort of using the idea of the egg is your cracked brain, and it's going to become sort of scrambled, if you will, if you use drugs, a lot of sort of fear-based messaging. On the bottom left-hand corner, you see, this is an image I took, I believe it was from the Boston subway system a number of years ago. What the image is that you have two brains, if you will, that are probably from a PET scan. And the caption on the top, it's hard to read, but it says, "Thinking or drinking, what will it be for your kid?" And so you have these two brains that are juxtaposed against one another. Presumably one here is the one that is the quote unquote drinking brain. The other one is the non-drinking brain, sort of implying a certain sort of normative aspect of the drinking brain versus the undrinking brain as being sort of good or bad. Again, these are themes that like Joseph Dummett and others have talked about for many years, about sort of how brain is sort of incorporated into our sort of day-to-day life and identities and sort of its normative underpinnings. Promoting mental illness within a brain disease framework to the public is a way often argued to combat stigma as sort of being value neutral. It's someone's brain, it's not their fault. They may engage in certain behaviors. Neuroimaging or brain scans are a key player in many of these conceptual changes and hopes for diagnostic and predictive tools. This is an ad from a few years ago from Allstate Insurance. The title of it says, "Why do most 16-year-olds drive like they're missing a part of their brain?" And the image is sort of looks like a cutout of a car coming out of their brain and their sort of frontal cortex, which is sort of the area that's often or involved in decision making. But just to highlight some normative language here that comes right out of this ad. And it says, because when that happens, when they drive without, because they're missing a part of their brain, it's not really their fault. It's because their brain hasn't finished developing. The underdeveloped area is called the dorsolateral prefrontal cortex. It plays a critical role in decision-making, problem-solving, and understanding future consequences of today's actions. Problem is, it won't be fully mature until they're into their 20s. So here we really see not only just drawing upon language of neuroscience, but invoking sort of themes around fault and blame and responsibility. So, and really tying that to the functioning of the brain in this ad for insurance. And so the brain as the location of the modern self is really, it's no historical accident. There's been multiple sort of histories that have sort of led us to where we are today. It's the site of the mind-body problem, where you have the social and biological interface. And so the modern neuroculture does reinforce what we might argue is a reductive materialist view, that human beings are essentially their brains. And I think what has emerged sort of within and what others have argued, like Vidal and Ortega, has this anthropological figure of modernity, or what they've called the cerebral subject of highly industrialized and medical societies. So because, the brain you might be considered the modern seat of the soul, or is considered perhaps essential to our identity, brains and selves are become inextricably linked to both in-groups and out-groups, and which is really sort of core feature of stigma. So stigma has been theorized as a process, as a social process that is enacted sort of as a process that includes various elements of labeling, stereotyping, power, which is critical and important, status loss, discrimination, as well as normative judgments of deviance. And this last part, I think, is really, really important to think about stigma ethically, is that there are differences that are made based on some labels or characteristics, and then a normative label of deviance is applied, which further others that person based on those characteristics. Scholars have also talked about stigma as a social determinant of health inequities, with stigma being rooted firmly in notions of prejudice, discrimination, and marginalization. And so one of the most stigmatized identities in history is that of a person who uses drugs. Addiction has been historically considered a moral condition, or a weakness of will. People are seen as being personally responsible for their substance use, which includes alcohol and the consequences of that use. And that is probably one of the main reasons why addiction is highly stigmatized. I'm not going to go over the various models of addiction that have existed over time, primarily in Western contexts. But this is sort of a key feature in contemporary debates. And so what the image that you see on the screen is from William Hogarth's 1751 etching, an engraving of something called Gin Lane. And he created this to illustrate the sins, or perhaps even the evils of gin drinking. So Hogarth portrays those who are living in poverty in what's called Gin Lane in England, as being sort of overcome, or even their lives have been destroyed by their gin consumption. And actually, this was very instrumental politically, as it helped advance the Gin Act in 1751, which greatly curbed and restricted how gin was distributed. So you see very shocking images here. Starvation, you see infanticide, decay, death. There's intertwining stigmas here of poverty, gender, and substance use that's built right into this. And has actually very much, even to this day, is like literally enmeshed in punitive policies toward people who use drugs, which would be sort of a subject of another talk, but just how that actually can lead to worse health outcomes. And so with addiction have long been considered a moral condition or a weakness of will. For over the years, many advocates, people who use drugs, researchers, clinicians, others, have sought to destigmatize addiction in many different types of ways. But one particular way is to bring it within a biomedical or a disease paradigm. And so the disease model or paradigm of addiction is really not new. I should mention, various disease models of addictions exist. Some of it has its roots in the 18th century from the American Benjamin Rush, who considered inebriety, or like drunkenness, if you will, as a progressive disease that gave rise to a loss of control over drinking. However, Alan Leshner's article from 1997, which is the headline of, I think really popularized and the notion that addiction popularized the notion addiction as a brain disease, and really helped to mobilize a movement with the brain as being the primary site of addiction. And this in very much way is he drew upon, not directly, but Bourse's sort of 1977 account of disease, in that addiction as a brain disease really was supposed to be value neutral. With many goals, one of them being destigmatization, and really to help reduce blame and responsibility that is often attached to people who use substances. So what is the brain disease model, or the brain disease model of addiction? So this is going back again to a paper from 2004 by Volkov and Lee, who were Nora Volkov, the head of National Institute of Drug Abuse in the United States, and Lee, I believe, was the National Institute of Alcohol Use and Addiction, NIAA. And so the statement here in their, again, a very highly influential paper, is they say drug addiction is a disease of the brain. and the associated abnormal behavior is the result of dysfunction of brain tissue, just as cardiac insufficiency is the disease of the heart, and abnormal blood circulation is the result of dysfunction of myocardial tissue. So the statement here is made to liken addiction to other medical diseases. So in this case, heart disease, to make it, quote unquote, a disease like any other. And so through this, trope or understanding of disease, the language of neural dysfunction produced by the drug is framed in terms of brain pathology. And so many advocates have argued that this view and modeling the language in terms of brain disease makes room for individuals who are living with, who use drugs, who are living with or are diagnosed with a substance use disorder, or living with addiction, to receive the same level of compassion and access to healthcare services as individuals who are living with other medical diseases, sort of like in this case, like heart disease. And ideally, this would also promote very progressive and enlightened social and legal policies. And, as mentioned, this again has also anti-stigmatizing goals as well, if addiction could be understood as, medicalized and not the individual's fault. And sort of within this, we might break it down to two different types of promises, or even you want to call them strategies, from considering addiction as a brain disease. So there's one is called sort of the epistemic promise, and again, a quote from Nora Volkov many years ago, sort of saying, is drug addiction a psychological or physical disease? Drug addiction is a disease of the brain. That disease translates into abnormal behavior. And there's also the therapeutic promise, and this is another quote that's coming from the Leshner article. And he states, understanding that addiction is, at its core, a consequence of fundamental changes in brain function means that a major goal of treatment must be to reverse or to compensate for those brain changes, elucidation of the biology underlying the metaphorical switch. So some people talk about a switch that happens or occurs in the brain that addiction is turned on, is key to the development of more effective treatments. And we see this even closer to us today. Not that that was so long ago, but with sort of new surgeries that are being sort of applied in the substance use space, like deep brain stimulation. And so we see at the cover of Harper's here, sort of the question posed, could surgery, and this is in this case, deep brain stimulation, solve the opioid crisis? And so we have surgery here, and pointing actually specifically to the nucleus accumbens, which is sort of one sort of structure within the brain that has been a lot of focus of a lot of addiction neuroscience research. And so the solution to the overdose crisis, which is, I would argue, is one of the major public health emergencies of our time, is being proposed in this headline as being solvable through surgery, specifically sort of deep brain stimulation. So perhaps an individual in highly invasive intervention as a solution to a broader sort of structural social public health problem. So we've, and I'm sure this is not news to anyone, here in the webinar today, but we've seen disease and brain disease framings in other areas as well, such as mental illness. So in the first paper by Pesco-Scalito et al. In 2010, the authors examined responses to vignettes in the mental health model of the 1996 and 2006 General Social Survey, who described individuals who met at that point the DSM-4 criteria for schizophrenia, major depression, and alcohol dependence, as the categories were called at the time. And so what the authors wanted to know is whether, first and foremost, the public embraces neurobiological understandings of mental illness, whether they endorse treatment from providers, including psychiatrists, and report community acceptance or rejection of people who are diagnosed with these conditions. And they found that in 1996, 54%, so over half of respondents, attributed depression to neurobiological causes, and that went up to 67% in 2006. They found that neurobiological concepts of depression increased the likelihood of support for treatment, but it did not affect perceptions of stigma. And actually, these findings were very much consistent with other studies that found biological explanations of mental illness can actually increase some aspects of stigma and reduce others. And so moving to the second one, we can see sort of where that happened in the Lohman and Haslam study. So what they did is they did a meta-analysis of neuroscientific explanations and stigma amongst 26 correlational and experiential studies. And what they found was that neurobiological explanations of mental disorder were actually associated with a greater desire of social distance. Specifically, they found a greater desire for perceived dangerousness, as well as greater diagnostic pessimism. But they were not linked to reduced blame. So there were some aspects of stigma that were increased with neurobiological explanations, and others were reduced, or they didn't, or they stayed the same. Pesco, Scalito, and colleagues updated their 2006 paper in 2022. Sorry, their 2010 paper, and they found that there were improvements in public beliefs about the causes of schizophrenia and alcohol dependence. And this paper was based on actually on the 2018 survey, and they noted a decreased rejection for depression, and they found that there were changes in mental illness stigma, but it appeared very largely associated with age and generational shifts. So I think that if you were older, you were less likely to report higher levels of stigma, and as well as if you were older as well. So folks have been skeptical of many of these brain disease developments from both sort of within psychiatry and out. There was this personal view in the Lancet a number of years ago by my Australian colleagues, Wayne Hall, Adrian Carter, and Cynthia Forlini, who were actually like, well, there's all this push around a brain disease model of addiction, but has it actually delivered on its promises, and it is actually something that's supported by the evidence? And they argued, no, addiction is still highly stigmatized. We still don't have really great treatments, and access and all those other issues still remain a huge problem. And people who use drugs are still highly criminalized. So moving to chronic pain. So pain is a common human experience, considered an enormous public health problem. It's the main reason adults seek healthcare, and it's variably defined, but typically it's considered that chronic pain is considered pain that persists for 3 months or longer. It affects approximately 20% of adults, costs billions and billions of dollars every year in lost work productivity. Approximately 60% of people who live with chronic pain also have concurrent mental health issue. And the burden of chronic pain is inequitably distributed. Those who tend to be most structurally disadvantaged bear higher burdens of chronic pain and have less likely access to effective treatment. Definitions of pain have varied throughout history and across cultures. But over time, models of chronic pain have become more neurocentric in both ontology and epistemology. We can go back to sort of Descartes' dualistic theory of pain, where sort of an injury or stimuli, such sort of first look at the top left-hand corner image from the fires, travels through the body, through the pineal gland, which Descartes considered, as you all know, where the soul resides. So maybe Descartes believed that pain was in the brain. We see a lot of scientific and technological advances from the neuroscientists as part of historical efforts to understand pain location and processing, including various theories such as specificity theory, intensive theory, pattern theory, gate control theory, neuromatrix, biopsychosocial. These theories and models have been very central to constructing pain as a very complex medical problem rather than merely a symptom of something else. And so chronic pain is an individual and subjective experience. And I think subjectivity is a key source of moral tension for chronic pain sufferers, as well as their family members, healthcare professionals, and scientists. So if an identifiable pathology could not be found for many patients, many were told that the pain was, quote unquote, all in your head, which is sort of a way to sort of dismiss as something psychological and perhaps not even real. So there was no medical issue. There was nothing here. So healthcare professionals didn't know how to help. Many people felt invalidated and dismissed. People report that people who are in pain report that healthcare professionals, friends, family members, coworkers often do not believe them about their pain or take them seriously. And so people in pain do very often struggle to be recognized. And this has contributed to immense stigmatization of people who are living with chronic pain. And this unease with invisibility and subjectivity is very challenging in a contemporary culture of biomedicine that's focused on identification of pathology, as pain is often refractory to objective assessment. And so the movement towards identifying, there's been a very strong movement with billions of dollars sort of invested in identifying reliable clinical biomarkers of chronic pain. And, of course, this stems from the intellectual history of objectivity in the West, the clinical pathological method in the 19th century. And I think, we do see this, how this is manifested in ongoing sort of funding supports from like the NIH and elsewhere. This research is still very, very much in its early stages, but the goal here is to identify reliable clinical objective biomarkers that can both predict and help diagnose and treat people with pain, largely because self-report of pain is considered sort of subjective and highly unreliable. And so, owing to the persistent advocacy of many people in pain, family members, researchers, clinicians, today, actually, we have a sort of structure of chronic pain from the International Association for the Study of Chronic Pain, which sort of divides pain into chronic primary pain and chronic secondary pain. And chronic primary pain is considered in this sort of taxonomy as not merely a symptom of something else, but a disease in itself. So this is very significant for many people living with pain, because you have within the ICD-11, or the International Classification of Diseases, you have for the first time chronic pain being recognized as a disease in itself. Chronic secondary pain is something that's considered more of a symptom. So this was lauded by many pain advocates and others as a huge step in legitimizing and recognizing their experience of chronic pain. But I also want to mention that these emerging biological models of chronic pain does not necessarily equal disease models of chronic pain. And I'm going to talk a bit about disease models of chronic pain in a moment. So adding the label of disease is inherently, a normative exercise, right? So considering something as a disease implies a biomedical ontology that itself is very powerful. And, so the normative aspect of disease implies that something is wrong. So a disease is a marker of deviance, of abnormality. And as discussed earlier around stigma, abnormality is very much central to the stigma process. And so we see this coming out through the pain literature. So a quote from this paper by Borsuk and colleagues on the pain imaging revolution. They say the major insight that emerged from neuroimaging studies is that chronic pain is a disease of the brain, and thus all therapeutic modalities will need to take this into consideration. We also see this kind of discussion from sort of the seminal report on relieving pain in America. Some types came out in 2011. Some types of chronic pain are, quote, diseases in their own right. The Canadian Pain Task Force, in its documents, this one from 2019, very clearly stated chronic pain is a disease in its own right. And part of the push toward including chronic primary pain as a disease in the ICD-11, we see in the paper, they said the ICD-11 will be the first to include chronic pain. Chronic primary pain represents a disease in itself. And various leaders in the pain community, like Dr. Mackey, who's been huge advocates and has done a lot of really groundbreaking work in the neuroscience of pain, has also been very public in his advocacy around chronic pain and disease. So, saying here chronic pain is a disease, chronic pain is more prevalent than cancer, diabetes, and heart disease combined. But what I find fascinating about this is that underpinning that, it says chronic pain is real. And it's really here's linking these notions of disease and medical legitimacy to the idea that chronic pain, yes, is real, but that's because chronic pain is a disease. But there's skepticism does exist within the pain community. So, for example, Ballantyne and Sullivan acknowledge that some chronic pain may be a symptom, others a disease, but a disease framing could have the negative effect of reducing patient involvement in treatment and the recovery process, which they see as essential to successful pain management. These authors are also quite worried about the increased medicalization of chronic pain, which suggests the need for certain medical and, in their view, namely pharmaceutical interventions at the expense of what they refer to as lifestyle or perhaps even non-medical strategies in order to help manage chronic pain. Looking at some of the empirical literature, so Dirodera and colleagues did a really interesting study where they found that participants are more willing to exclude patients from social interactions when no medical explanation for their pain exists. So this was a small study of 59 participants from the general population. They viewed 4 videos of 4 patients, each accompanied by a vignette describing the presence or absence of a medical explanation for their pain. Participants estimated the patient's pain and rated the sympathy they felt for, and also the inclination to help this person. To measure social exclusion, what they did is they indicated their willingness to interact with this participant or this person in pain in various types of social situations. So they used something called the social distance scale, which is often considered a proxy measure for stigma. And the participants were invited to select 2 of the 4 patients as confederates to play a game against another. And when no medical explanation for the person's pain was provided in the vignette, participants attributed less pain, reported feeling less sympathy, and were less inclined to help the person with their daily activities. I think what's of particular interest to me here is that participants were less willing to interact with people with medically unexplained pain, and selected less often than those people who had the medically unexplained pain than patients or people with the medically explained pain as the confederates in their social game. A survey that I've been a part of from across Canada, which we conducted a few years ago, which we're in preparation right now. We asked people adults who are living with pain from across Canada, a couple questions on the survey. One of them was, if a brain scan could show my chronic pain, my healthcare provider would be more likely to believe me. And just sort of quickly going over some of this. So we found 234 participants, strongly agreed or agreed that the brain scan would actually help their healthcare professionals believe them. We also asked the question, results from brain imaging technologies could be used to dismiss my self-reports of pain, and had them agreed. And about 189 participants, which is just over half, 54% of the sample, were concerned that results from brain imaging could be used to dismiss their self-reports of pain. So what's going on here? It can both be believing their reports of pain, but also dismiss their reports of pain. So what we're sort of taking away from this is that, so we were actually quite surprised, but on the one hand, we think that brain imaging could be actually quite legitimizing for many people in pain within sort of a biomedical context, because, but at the same time, participants were suggesting, well, if it could be used to dismiss my self-reports of pain, possibly could a brain scan supersede their own self-report in a case of discrepancy? So this suggests to us maybe that the way these technologies may potentially be used, which is one of the goals of these research programs, which is to be used clinically, could be both legitimizing and stigmatizing in different ways. Another study that we're currently undertaking with my group that's funded by CIHR is we wanted to have sort of 2 aims of this project. We want to investigate the effects of brain disease explanations of chronic pain on the degree to which people without chronic pain stigmatize others who live with chronic pain. And then we have a second aim, which is a qualitative interview study, where we're exploring the influence of brain disease explanations on stigma with people who live with chronic pain, and as well as healthcare professionals. So just going to go very quickly through this. So what we did is we gave adults in Canada and the US a vignette study, and these are adults who do not live with chronic pain, and they were randomized to one of 5 vignettes, and only one vignette about SAM and the explanation for their pain. And they didn't know the other conditions existed. And so they were randomized to either a vignette that talked about chronic pain having no physical cause due to the biopsychosocial model, disease model, brain disease model, and then we kind of threw everything together with brain disease model biomarkers, and we included this funny cartoon image of a brain. And so you can sort of read the vignette here, and then they were asked to answer a bunch of questions about SAM, and we also used the social distance scale to measure their social distance. So overall, we had 508 people participate, and these are some of the sort of some findings, which I'll just share with you here. So when compared with the vignette that explained Sam, who's the person in the vignette, their pain was due to no physical cause. Participants who saw the disease and the brain disease vignettes perceived Sam to be in more pain. Sympathy towards Sam was also higher if they saw the brain disease, the biomarkers of the disease vignettes. They actually, unlike the other study that I mentioned, they were more willing to help Sam with their daily activities. Disease and brain disease explanations, participants thought that Sam was less likely to be exaggerating their pain, and also that Sam was perceived to be more likely to be telling the truth about their chronic pain, which is very interesting because in this way, what this suggests, at least to us, is that disease or brain disease models are conferring a medical legitimacy. And so Sam was thought to be in more pain. They actually had more sympathy because Sam was considered to be diseased and thought that they were telling likely to be telling the truth because they had a disease versus something that had no sort of underlying physical cause. We're currently in the process of interviewing people who are adults who are living with pain from across Canada. I'm just going to share a couple quotes with you to sort of get a flavor of the kinds of things that we're hearing from people. So we're asking people about their perceptions of disease explanations of chronic pain, brain disease explanations, as well as how that sort of factors into their life and interfaces with stigma. And Bailey, these are all pseudonyms, by the way, said, pain is one of those situations where it's not quantifiable. If you can prove the objective existence of pain, then at least it gives the person a sense that they aren't losing their mind. They can take a piece of paper, like the brain scan, to the doctor and say, look, I told you this is happening here. Now you actually have to listen to me. If you're not finding value in what I'm telling you, at least you can find value in this objective report. Sachi says, it's reductionism that's the issue. I don't want to see a certain deference to imaging to be the all and end all. So to be the end all and be all. I mean, in the chronic pain world, there's already an issue of the bio being heavy and maybe even the psycho being more heavy than the social component of chronic pain. All this is to say that neuroimaging has its limits. It can't be and shouldn't be the all and the be all and end all to sort of have similar language. So we see here both people, participants are, at least there's some tension here. Some are maybe looking more in favor in terms of this legitimizing. Others are a little more concern. So I'm going to talk a little bit about sort of now just to, at the end, sort of considerations for pain stigma. Dumit and others have sort of long talked about this in the context of mental health. But I think, with biomedical imaging and brain imaging in particular has been able to construct ideas of both truth and objectivity about conditions like chronic pain, mental health, and addiction or substance use. And has inadvertently helped to create new, kinds of people in sort of the hacking sense who are identified and described in terms of their brains. So I think I'll argue that this actually presents both ethical strengths and vulnerabilities in the case of pain stigma. So scholars have long argued that because pain, have argued that since pain has been long considered a symptom rather than disease, this has actually contributed to the oversight of chronic pain in public health context. So we can see how it may medicalize and legitimize a contested condition. Possibly this might lead to less stigma, but that's an important empirical question. It may lead to increased research and treatment funding and resources for the disease of chronic pain, which could stand to benefit people. And ideally, this may also lead to more compassionate treatment and as well as policy responses, potentially around disability rights, for example. But there's a lot of more sort of ethical vulnerabilities here, and this is where I'm going to focus most of my my attention. So, neuroimaging data has been used as, I think, as a particularly persuasive tool in reinforcing a kind of neuroessentialism. And so the idea that the essence of identity can be reduced to the brain. So in other words, you are your brain. And you can see in this image here, you have so-called normals juxtaposed into very sort of stigmatized categories of quote unquote alcoholic, obese, or cocaine dependent. So much like Dumit asked like 20 some odd years ago, which kind of brain do I have? Where do I fall into? And more importantly, am I normal? We also see studies that have looked at biological explanations of mental disorders and found that this actually evokes less empathy in healthcare professionals than in others. So clinician empathy may also be affected by biological explanations versus, let's say, psychosocial explanations as well. Some additional sort of ethical vulnerabilities for consideration. It may, brain disease models of pain, for example, may legitimize the disproportionate use of invasive or risky neurobiological treatments. So, for example, um, we saw the example earlier around addiction and deep brain stimulation. Not that there couldn't be people that would benefit, individuals that could benefit from it, but often perhaps, this may prioritize interventions that have higher risks associated with them or potentially even be more costly than more broader, let's say, public health approaches. So again, to the second point, many of these may come at the broader expense of broader public health and preventative types of approaches or overall sort of policy responses or design that may help compress some of the inequities associated with chronic pain. And as my colleague Wayne Hall said over 20 years ago, in the context of addiction, with the focus on the brain as sort of the site of addiction, but in this case, let's think about it in context of pain, it could be a disproportionate focus on what he called great and desperate cures. So the potential also for exploitation, sort of increased types of treatment focus that may be very costly and come with great risk. There's also been some very important STS types of critiques around brain images in the context of addiction. Lena Hansen and others have written some really important papers in this regard. Specifically, that brain image may symbolically convey an unmarked universality of neurophysiologies, and they sort of do not account for sort of intersecting factors such as racialized status, gender, ethnicity, age, and poverty. So Hansen and colleagues critiqued brain disease model of addiction very specifically, and they argued that brain disease models actually in addiction or brain images serve to benefit actually a privileged white population by helping them to drive them into medical spaces to receive treatment for their disease. So if you have a brain disease, this can something ideally that can be treated well. They argue that non-whites are disadvantaged by such framings and are driven to systems of criminalization and control. So I think this is important to consider, who benefits and who might be harmed by these certain types of framing. The pain management context is one that is ripe for epistemic injustice. I think despite the goodwill of clinicians, epistemic injustice can intensify the stigma directed at people living with chronic pain. And I think considering the anticipated use of brain imaging to help identify brain-based biomarkers of pain, some clinicians may actually prioritize what they consider to be objective medical evidence in a chronic pain context over patient testimony. Chronic pain as an individual and subjective condition, there's no real objective test that can determine if someone is in pain or how much pain they are in. And so in some literature, there is an expressed interest in using some of these brain-based biomarkers in what's called a painometer or a painometer, which is some have been concerned that this could be used as a de facto lie detector test. Despite understandings that chronic pain is a complex lived experience with multiple dimensions. So the idea is that someone clinically may undergo biomarker testing, which could determine sort of the level and extent to which pain that they're in based on the various neurosignatures. So I think this tension here between a desire for objective findings versus sort of the subjective experience of pain, some have argued that is likely to unjustly deny people who are living with pain treatment or potential for compensation. It could also exacerbate issues of trust or distrust of people living with pain. And I think, importantly, from a context of epistemic injustice, potentially undermine their credibility as informants, especially if there's a discrepancy that comes with some of the, the objective findings and the person's self-report. And also, I think if thinking intersectionally, we can see potentially how disease framings can converge with other aspects of identity to legitimize or delegitimize or denigrate someone's experience of pain or their illness. So, for example, women, disabled people, people with gender nonconforming, individuals who are racialized as minorities are all currently less likely to have their experience of pain taken at face value, given that their status as credible knowers is often determined by markers of social power. So I'm worried here that the way this potentially may be used may further intensify some of these. So addiction and chronic pain are contested conditions. They're marked by disputed medical, legal, and cultural definitions as well as contention. Because they're contested, many clinicians and scientists and advocates are motivated not just by sort of a medical explanation or medicalized explanation, but also by the desire to undermine stigma and to legitimize addiction, mental health, chronic pain as real diseases. And I think these are laudable objectives. But I think ironically, we've sort of had situations where certain people are made up. We have produced new disease identities, such as the addicted brain, the pain brain. These diseased kinds of brains are held against normative universal ideals of what might be considered a healthy brain, and reinforcing culturally salient notions that different types of brains refer to different types of people. So there's a lot of similarities here, I think, between brain disease models of addiction and pain, but there are some differences too. As noted here, partly one that we have the addiction is premised on, a weak will, which we don't have in the context of the pain context, but there's others, I think, areas where they're very importantly overlap. So should chronic pain be considered a brain disease, and does it matter? And here I'm drawing a lot of inspiration from Quil Kukla's sort of excellent paper in the Journal of Philosophy of Disability. So where sort of they ask, like, calling something a disease actually may serve various strategic goals. And so I think we can see that here in the pain context. So calling chronic pain a disease or a brain disease may have various sort of epistemological, clinical, economic, social, and ethical strategic goals that may work to benefit lots of people with pain. And these should be acknowledged and recognized. And I think we're seeing that as from some of the empirical literature on people who are living with pain and sort of what they see as their motivators, as well as researchers and clinicians' motivators for calling something a disease. But it may be a disease in some contexts, and it may depend on type. So, right now, the current classification of disease is like a primary chronic pain is considered a disease, where a secondary chronic pain is not. But Kukula also asks, I think, a really important question in this paper, which is relevant for sort of the topic here today, is that they ask sort of who exactly is helped and who is harmed by counting this as a disease. Will it stigmatize or destigmatize people with the condition? And I think we're still sort of learning more and figuring that out, but I do have my worries about this. So I think the disease framing of chronic pain, particularly as a brain disease, can be understood as an attempt to bring chronic pain or along sort of multiple histories of attempt to bring chronic pain under the auspices of medicalization, such that its uncertain and uncontested status is solidified. The historian Nancy Campbell, who I'm sure many of you are familiar with, has argued in context of addiction that with respect to addiction, making the brain the object of focus provides a unified framework for many scientists to draw upon, as well as resources. And it also has the authority of neuroscience in terms of its explanation. And providing, an explanation or a medical or brain-based explanation of something as etiologically and complex as chronic pain may provide a sense of objectivity and value neutrality for many people, as well as some comfort to clinicians who I believe, are trying to do the best that they can by their patients, although there's notably considerable harm that has arisen. So there may be actually good strategic reasons why chronic pain should be considered a disease or a disease of the brain. But I think this can also exist along the unintended consequences of increased stigma. So I think what we're seeing here is that there may be a cautionary tale for chronic pain. A brain disease model of pain may be what Lohman and Aslam has called a mixed bag. So we see, some like sort of presented from the data that I shared, some aspects of stigma may inadvertently be increased, while others may be decreased, such as reduced responsibility. But I think the most important message here around stigma about pain is that pain itself is not inherently stigmatizing, and pain itself doesn't stigmatize. People stigmatize. And stigma is very much structural, embedded within our policies and laws and our interactions. And so I think, we shouldn't think that something like brain-based or medicalized explanations of pain will necessarily do much to alleviate the huge burden of pain stigma, especially as it may disproportionately affect structurally vulnerable groups. So I will end there and looking forward to the discussion. Thank you.